And most importantly, on a large scale, strategic scale, with you being on the subcommittee to set the reauthorization for Older Americans Act, that covers so many things that we and all area agencies are doing. And you're really listening to the concerns of us as providers, not so much worrying about ourselves, but trying to figure out the best way to deliver service so people can age in the community. So you have been a long-term supporter, and we really appreciate it, and we're very proud to welcome you to JABA.
Thank you, Marta. Thanks to all of you. What a great welcome, and I'm thrilled to be here at JABA. And we're going to have, I very much value the area agencies on aging. When I moved to Richmond in 1984, one of my first friends, it was the person my wife, my then fiance, was rooming with, a couple named Jim and Mary Payne. And Mary Payne was the head of the Richmond area agency on aging for many, many years. And that was my first kind of entree, long before I was in city council and mayor, into the work that the area agencies do. Obviously, over the course of my time in state government in particular, I worked really closely with the area agencies. And now in the Senate, on the Health, Education, Labor, Pension Committee, we deal with a lot of issues that really touch upon these agencies, especially the Older Americans Act. There are other committees too. Finance does Medicaid and Medicare, other committees that touch upon the work. But the committee that probably deals the most with area agencies on aging is Health. And it's a great committee to be on. I'm on Armed Services, which is a great committee. I'm on Foreign Relations, a great committee. But those were sort of committees like when I walked into the Senate at age 56, like a new issue put in my hands. The Health Committee is the committee that takes advantage of the 16 years where I was a local and state official, because healthcare issues, education issues, labor.
Say that when I started a Medicare counseling session, new Medicare, I tell people, I said, nothing in your life prepared you to understand Medicare. I don't care where you did in life, nothing prepared. So we're going to start from scratch. And they're all sort of relieved about that because they realize they're not an idiot.
Yeah.
They're like, everybody else is an idiot, we're all together. So
they're not alone in not understanding.
Yes.
Well, that is a helpful thing, kind of demystifying it in that way for people and saying it's complicated. But to kind of go back a little bit, the addition of the Part D, Medicare Part D prescription drug benefit was very definitely a positive thing, very good thing. The innovation that we're doing in the pharmaceutical space is part of the reason that life expectancy has expanded. My parents are both 90. And they're very healthy 90-year-olds, but they need medications. Now, one of the medications my dad gets, he gets from Canada because of cost issues. It's a glaucoma medication, and that's, there's a lot of people who are having to do that. My dad loves nothing more than to research, so he spent a lot of time to try to find out the way to do it. But obviously, I'm thrilled that we have pharmaceuticals that are enabling people to live longer. My parents still live in their own place, and so that's great. But the mistake in Medicare Part D was doing it in such a way that we were not negotiating on prescription drug prices. And it was a particularly egregious mistake because the federal government does negotiate for prices in the VA system. So we even had a sense of, if we approached, purchase of pharmaceuticals from the federal standpoint and really were negotiating, we kind of know what price we might get on the negotiation. So we can compare what happens in the VA to what was happening in the Medicare program. And that excess cost in Medicare Part D is a cost that falls on individual shoulders. It also falls on the federal treasury. So dealing with deficits, dealing with other issues at the federal level, why wouldn't we, in this program, which is the biggest part of the federal government? If you ask people what's the biggest department of the federal government, everybody says the Department of Defense. Nope, the Center for Medicaid and Medicare, CMS, has an even larger budget than the Department of Defense. So why wouldn't we use traditional kind of commercial best practices to try to get best prices? The idea was we would pick 10 drugs that are very commonly prescribed under Medicare. These 10 drugs account for about 20% of the prescription drug costs in Medicare. Biden administration picked the first 10, engaged in a negotiation with the industry. And the idea would be the prices would be negotiated, and then beginning in 2026, we will start seeing the benefits of those reductions. And there will be benefits both to the Treasury and to individuals. Industry doesn't like it. You know, they what I call negotiation and commercial best practice, they call drug rationing or whatever. They're bringing lawsuits to try to stop it. That's their right to do. But I think we're going to prevail on that, and we're going to move forward in doing the negotiation just like we do through the VA. And if we do that, it's going to save a whole lot of money. And the idea is, you know, we pick the 10 that will be 20% of the total spend for 2026. There will be another set of drugs that will kick in 27. And we will, in a reasonable way, not trying to do everything at once, because if we did everything at once, we'd probably make some mistakes along the way, but in a reasonable way, we will roll out the negotiation for, you know, all these major categories of drugs that are used heavily in the Medicare program. So that's number one. The third thing, and the one that I'm kind of the most psyched about, is the cap on total prescription drug costs. My parents, again, extremely healthy 90-year-olds, but they use a number of medications, and the out-of-pocket costs can really rack up. And we kicked in January 2024 with no more than $3,000 a month total out-of-pocket costs for Medicare, and in January 1, 2025, that will go to $2,000 a month. I've already had testimonies and hearings like this about what the $3,000 a month has meant. I did something in Loudon and had somebody from a neighboring county, Fairfax, say, look, you know, this, just the $3,000 a month is saving me like $8,000 a year. He's a pretty healthy guy, but he was taking a number of medications and was paying more like $11,000, $12,000 a year in out of pockets. And he said, I could afford it, I'm not poor, but I'm also on a fixed income. And to go from, you know, 11,000 to 3,000, he said it's just a dramatic improvement. When you go to 2,000, then you're talking about $180 a month, whether you're on one medication or 10 medications. You know, you can make it no more than $180 a month, and we put a provision in, as you know, that enables that cost to spread. So you don't have to spend $2,000 to then not spend anything, because sometimes people don't have $2,000 lying around. You can spread that cost over a year, and most people can figure out a way at $180 a month, particularly if they're using multiple medications, figure out a way to do that, and it will save folks an awful lot of money. I'm really excited about that provision. That was my favorite one of all the IRA provisions. The IRA passed by one vote. It was one. I've done three things in my time in the Senate where I have been a deciding vote. You know, if I had not been there, it would have gone the other way. The IRA was one. The Affordable Care Act, maintaining it rather than destroying it, was the second one. And then the third was the American Rescue Plan, which had an awful lot of healthcare stuff in it, because it was about the deployment of vaccine. So the 3 one-vote efforts that I've been involved with, it's interesting, they've all touched on healthcare, which just shows how central kind of healthcare is to our policy discussions.
You ever see the possibility for Medicare becoming its own benefit manager, similar to the VA model?
It would, yes. I just introduced a bill yesterday for the second time called Medicare X. I want CMS to develop an insurance policy that they would offer to working people by putting it on the exchange. It would have the essential health benefits that are required under the ACA, but because CMS doesn't have to collect a profit margin, pay fancy salaries, advertise on TV, set up a distribution network, they're already in every zip code. The CMS-based policy could be, I think, very affordable compared to others who would force people to buy it, and you can go shopping on the exchange. It would be favorable. So we are talking about an expanded role for CMS, both in the way that you mentioned, could they be their own PBM, but also could CMS even offer a more affordable health insurance policy that people could, at their option, choose during their working age years. So yeah, early discussion things.
And also things like, I was just on the phone recently with a higher-up person in Social Security Administration in the Richmond office, and it was actually told that the local office can't tell people to go to the LICAP office. And I'm like, I don't understand that. That's a federal program and a federal program. Why can you not advise people to come over here, even though our local one does? So,
yeah, that's
yeah,
a little bit of the silo effect.
yeah. And I agree with Don, is that the SHIP program, and as it comes down to the different states, and Virginia VICAP program, is little known, but highly valuable because it's the one place that Medicare beneficiaries can go to that is unbiased.
Mm-hmm.
We're not trying to make a profit. These are all volunteers.
Mm-hmm.
And so the advice we give isn't based on a profit margin.
Yeah. Are you guys running into the drug shortage issue? Because that's an issue that I didn't bring up. I introduced a bill yesterday that was very bipartisan, a bill with J.D. Vance, a bunch of folks to try to grapple with drug shortages. Is this something that you're running into?
Here, UVA for our outpatient pharmacies. We've actually created, which is kind of an industry first in the big pharmacy that I know of in Virginia, this health system-wide drug shortage task force that literally looking at what drugs are on shortages, sending out messages to providers so they know. So that's always usually the hardest thing is patient gets a prescription, you do some medication authorization work or something, you get it just paid for, or someone going there, you get what's covered, and then they can't get it, and they have to start all over again, or just wait, and queues, and it's hard to manage from the pharmacy's perspective. I'm sure it's very hard to manage. I know it's very hard to manage.
Very well, so when I try to prescribe something that could be the only correct.
Yeah.
Oh no, they react to it. So there are ways around drug shortages, but there are some critical drugs, particularly in the hospital setting, that really the hospital system needs to function well, and those are in short supply. It's a major implication for patients' health.
And do you do not only individual casework, but do you have like, a retirement 101 class, or, where you encourage people to access this maybe a couple years before they're Social Security eligible? I could have used that before I turned 65, but I don't remember ever anybody suggesting to me that I should do that.
They're very well attended and well appreciated. We always tell them, we said, we're going to give you enough information to be dangerous, and then now you need to come, you got enough information now to come and do a counseling session.
Yeah.
Our problem in our area, and I think across the state, and it touches into a larger problem, is salespeople, brokers or so, who are focused on a single company, on a single type of plan. They are very active in doing talks in the community, come and do this. And most of it revolves around this. I'll get them started because they'll go crazy here on me. But on Medicare Advantage in the state of Virginia. Medicare Advantage plans work well in other parts of the country, and but we don't live there, we live here. In Virginia, Medicare Advantage plans have a lot of drawbacks, and not necessarily advisable for the average Medicare beneficiary at the moment. They could get better in a few years.
Well, what would be the difference between the way Medicare Advantage works in some places successfully and deficits?
Yeah, I was cruising along on her original Medicare with a Plan F supplement, and somewhere along this path, her prescription drug prices went up. And I don't know how the contact occurred between her and a Medicare Advantage salesperson, but all of a sudden, she's in a Medicare Advantage plan. The worst thing that she could have done, because she's in her 90s, she should have, she's going to, sure enough, she ended up in the hospital. It was, I'll use their name, Humana, started denying care. She needs to be placed now into a skilled nursing facility, Humana, denying care. So yes, maybe her outpatient prescription drugs were covered, but now she's saddled with huge medical bills for what Humana is requiring her to pay out of pocket, and that's how Advantage plans work. It's a lot of out of pocket when you're most sick, most vulnerable. And don't call it Medicare, please. It's not Medicare. It's Advantage. These are not, this is nothing like Medicare.
The thing I hear from Medicare Advantage beneficiaries are, I like my Medicare Advantage plan until I have to use it.
At the same time, we have what I would call predatory advertising practices on behalf of the Advantage plans. And it gets particularly egregious right before and during open enrollment. I mean, if there could be something be done to regulate the amount of advertising, the barrage it seems to be hit with, as you know, just turned 65. But open enrollment is, I've seen it now 3 years in a row, become more and more and more egregious. And it really does affect our ability to counsel effectively, because we spend half the time fending off misinformation.
Yeah, kind of.
Per month fee on many of these plans is so low.
Yes.
That people
I
look
see.
at that and
Yeah.
think it's covering everything that they're getting in their supplement plan. And they just don't. And, you know, they saw the ad, they talked to the broker,
With this, maybe occasionally 40 years ago or so, it's a daily thing.
That's very unfortunate. Wow.
The cost and the co-pays, the doctor availability, these are major problems.
Yeah.
The other major problem is that they have a very high denial of services, right? Something about 9%. And,
Wow.
And-
Sometimes people aren't completely aware of this. There's a Bureau of Insurance at the Virginia State Corporation Commission. And so some people think insurance, oh, it's regulated, so if they're offering it to you, it's probably going to be good. But the way the Bureau of Insurance operates is there is essentially no regulation of plans that are in competitive markets. Insurers are required to file the plan, like if we're going to change the plan, have to file it so that it's on public, available for public review. But the SCC only really regulates insurance in industries that aren't deemed to be competitive industries. So like somebody that's going to insure a blasting operation, well, if there's only 2 insurers in the world that do that, okay, the SCC will regulate prices and terms there, but on everything else, they just require filings every time you change your plan, but they don't really regulate terms and conditions or pricing. So some people maybe get pulled into thinking, oh, it's a company and they're registered with Virginia and there's a Bureau of Insurance, so we're probably okay. But the answer to that is no, they don't really put any limitations or protections in.
yes.
This is a very helpful conversation, and I really appreciate you taking the time to do this today. We will pass on some of these thoughts and ideas to Samantha, but please know whether it's JABA or the network of our agencies, we want to be helpful, and we realize that we've made some progress. That's great, but we have more to do.
Well, and we appreciate that, and I guess being the area agency on aging, I just have to take us up one level
Great.
and say, if we were to do a better job of funding the social determinants of health,
Yeah.
of funding community-based services, then it would become healthier for people, and some of the costs we're talking about would become a little bit less of a problem. And so I think as Congress and as you're reauthorizing the Older Americans Act, that's a big piece, is to think about it's not just the best way to help people age in the community, it's actually the most cost-effective way. I know certainly when I've had discussions with local legislators in the past at the state level about Medicaid, because they like to complain that Medicaid, seniors in nursing homes cost Medicaid a lot of money. And my point to them was, if you would do more to help us keep them in the community, it would be much less expensive. And I don't know anybody who wakes up and says, hey, could we go sign you up for a nursing home today? So it would serve a lot of purposes, and it just means changing that mindset so that we as a country, as a commonwealth, think differently about where we can intervene, and we need to intervene sooner with what didn't used to look like health care, but 40% of health care is social determinants. The medical care, no offense, Dr. Murray, is a very important piece, but really, and you know best of all, because geriatricians really
His
get
job
it.
would be a lot easier if we did what you were doing.
And what you do and what you can suggest to people ends up being a lot of what then comes to us. So, as the area agency, I have to kind of bring that.
Good. All right. Well, maybe there are ways in the Older Americans Act reauthorization that we can think that way and do more that would, accomplish the objective that you were describing. So, all right. Well, thank you all very much. Appreciate it.